The task given to me today is to talk to you on optimizing the hematocrit in obstetrics the rational way, and this is the first pillar. So as defined, the patient blood management is the timely application of evidence-based medical and surgical concept designed to manage anemia, optimize hemostasis, and minimize blood loss in order to improve patients' outcome. In patient blood management, we do not need to transfuse patients who do not need blood urgently. However, those who require transfusion, they should receive the minimum amount of blood that will keep them safe, and it should be given quickly. So the history of patient blood management hails back in 2005 by Professor James, who actually realized the focus of transfusion medicine should be changed from blood products to patient. And this was further endorsed by the World Health Assembly. And in 2017, it was recommended as a standard of care by the European Commission. And the WHO Action Framework has actually listed patient blood management as one of its 6 goals. So in optimizing hematocrit, what we would do is peri-operatively or pre-delivery, antenatally, we would screen the mother for anemia. We would identify and manage the underlying disorders causing anemia, and we should treat the iron deficiency anemia of chronic disease. And intrapartum or prior to delivery, we should actually ensure that the patient is hematologically optimized. And in the post-op period, if she has suffered a postpartum hemorrhage, then we should correct that anemia by giving iron, which could be oral or it could be IV iron. So the measures during pregnancy is first to identify anemia and its cause, then to treat it, then early treatment of iron deficiency, optimizing red blood cell before delivery, and identify women who are very high risk of postpartum hemorrhage and plan their delivery in a tertiary hospital. And if possible, we will arrange for a cell salvage so that they can receive their own blood as a replacement. Antenatal anemia is a modifiable risk factor, and it is a predictor and is definitely associated with higher incidence of perioperative blood transfusion, alloimmune sensitization, and surgical site skin infection. And because of these problems, there may be prolonged hospitalization and even increase in hospital costs. And this is an independent risk factor for venous thromboembolism. And anemic mothers can actually also die from this condition. So what is the burden of iron deficiency globally? WHO has defined anemia of a hemoglobin of less than 11 grams per deciliter in a menstruating female. And in pregnancy, at term, we expect the hemoglobin to be more than 10.5 grams. Sadly, more than 30% of the world population is still anemic. And anemia in pregnancy and patients going for elective surgery is definitely an independent risk factor for morbidity and mortality. In the past, we actually saw topping up of hemoglobin using blood, but I think today we have changed our management using the patient blood management, in which we resort to iron if there is iron deficiency anemia in correction of anemia. Blood transfusion itself is an independent risk factor for poor clinical outcomes. And the reason these drivers, there has been a paradigm shift from product focus to patient focus in transfusion medicine. In this article in the British Medical Journal, Improving Patient Blood Management in Obstetrics, an audit was done in a tertiary hospital, and it was found that 12% of maternity patients who had postpartum hemorrhage, primary postpartum hemorrhage, were really anemic on admission, and there is enough evidence to show anemia increases your risk of postpartum hemorrhage. And of this group, 58.3% required transfusion, and when it was compared to women who were not anemic, only 17.88% actually required transfusion. So correction of anemia in the antenatal period is definitely crucial. In Malaysia, among pregnant women in Malaysia, 80 to 90% of them have low iron status, and 38 to 40% of them actually go on to develop anemia. The American College of ONG has put up this to say that active identification and correction of anemia for all preoperative cases is essential, and that is what is actually practiced in our hospital as well. So women who have heavy menses are one of those who are prone for iron deficiency anemia. And if they have a ferritin of less than 20 nanogram, definitely they're prone for iron deficiency anemia. So poor outcomes of anemia prior to surgery. In the study, they compared anemic patients and controls, and they have seen that anemic patients, among anemic patients, those who required transfusion was 71% compared to non-anemic patients, which is 10.5%. And among those who are anemic, they were also prone for higher risk of urinary tract infection as well as respiratory tract infection compared to the control group. So when do we diagnose iron deficiency anemia? We will send the iron studies, which comprises ferritin, total iron binding capacity, and transferrin saturation. And if the ferritin is less than 30 nanograms and the transferrin saturation is less than 20%, then we would make a diagnosis of iron deficiency anemia. So what are the benefits of patient blood management? It definitely has better patient outcome, and it is cost effective. And in this study, we have seen that there's a reduction of transfusion with the practice of patient blood management for up to 95%, and mortality has reduced up to 68%, and the length of stay in the hospital has reduced up to 33%. Readmission and re-surgery has also reduced by 43%. Reduction of morbidity up to 41%, and the length of stay in the hospital has also reduced. So is it time to change our transfusion practice? Yes, because we know that blood transfusion has got safety issues. One is infections that can be transmissible, namely the HIV, hepatitis, and even the COVID-19 infection. And of course, transfusion doesn't go without any risk of reaction. And studies have shown that there's increased morbidity and mortality and adverse outcome in patients who receive blood transfusion. And there's an increase in the cost of blood. Blood is not free. And of course, with the aging population, many parts of the world, in fact, in Malaysia and in Penang too, sometimes there's a shortage of blood supply. So, but with blood transfusion, these are the possible things that can happen, from infection to embolism to pulmonary complication to increase admissions to ICU and length of stay, and of course, increased risk of hospital mortality. So is the stored blood actually as good as giving a fresh blood? Definitely not, because the stored red blood cell loses its nitric oxide and is not able to deliver oxygen in the same way as fresh blood is. So the blood storage lesions, what happen is that storage lesions results in depletion of ATP to 3-DPG, decrease in nitric oxide, decrease in tissue perfusion, and increase in inflammatory products, which then results in decreased oxygen delivery and increased inflammation and bacterial infection. Now, when do we decide to transfuse? For preoperative transfusion, in 1942, Adam and Lundy proposed the 10-30 rule, where the hemoglobin should at least be 10 grams and the haematocrit should be 30%. But in 1999, this was reverted by Herbert, who studied the effect of restrictive strategy versus the liberal strategy, and a hemoglobin of at least more than 7 grams would definitely be effective for the patient to undergo a surgery. We know that 40 to 60% of transfusions were inappropriate, and the modifiable risk factors that contributed to transfusion is the presence of correctable anemia, excessive surgical blood loss, excessive blood loss due to unnecessary testing, uninformed and poor transfusion practices. So it's time for us to focus on our patients and not on transfusion, and transfusion should actually be our last resort. We should plan early, have adequate time to improve the hemoglobin of our mothers who are pregnant prior to delivery, or for our patients who are going for surgery as well. And if we resort to transfusion, then we should try to practice a single unit transfusion. Restrictive blood transfusion threshold and reassessment after single unit transfusion should be incorporated into clinical practice in all areas. Looking at the health economic perspective, patient blood management falls under the prime quadrant. It has good outcomes. There are numerous papers to show this, and it is cost effective as well. In our hospital in Penang, relating to this topic, we have done a couple of audits from the year 2007. The first audit was done when we realized that many women admitted with heavy menstrual bleeding were actually given blood transfusion. And what happened was the junior doctors were just looking at the number on the blood form and transfusing patients. So we prepared a new guideline where we had to assess the patient as a whole, looking at the hemoglobin, the vital signs, and the symptoms if the bleeding was controlled with other medication or measures. And with that, we were able to reduce our transfusion from 55% to 7%. A second audit was done looking at the cross-match transfusion ratio in our department as well. And usually the obstetric and the ONG team, we have a gynaecologist in our services in our hospital. Hence the request for blood prior to surgery is a lot, but however, the transfusion is reduced because they take measures to reduce blood loss during surgery. So what happened was, rather than just requesting for 4 pints of blood, we came up with a maximum surgical ordering schedule based on the usage of blood for different types of surgery. And with this practice, we were able to reduce the cross-match transfusion ratio from 6.7 to 2.4, which is what is a norm in Malaysia. A third audit was done recently, and this looked at the improvement of hemoglobin with antenatal iron infusion. And we have mothers of different age groups and different parity at different gestational age who came in with a HB of 7.8 up to a HB of 10. And these mothers were actually given IV iron, and their increment of hemoglobin was from 8 to about 42%. Another audit was done for postnatal mothers who actually suffered from postpartum hemorrhage. And in these mothers, we didn't use blood to correct their hemoglobin, but we also resorted to IV iron, which is given immediately after delivery, prior to discharge. And in these women, we were able to increase their hemoglobin by about 42%. So iron replacement in Malaysia are available in 2 forms, oral iron as well as intravenous iron. And the oral iron that's available is ferrous sulfate, ferrous formulate, and ferrous gluconate. And as we know, oral iron, bioavailability of iron is only 10 to 15%. And there's always an issue with compliance. Mothers actually don't like taking iron because of the odor and the aftertaste. So the IV iron that's available is Venofer, Cosmofer, and Monofer. And in our hospital, we use Venofer for our pregnant mothers. So correction of antenatal iron can be done by using oral or intravenous iron or even recombinant erythropoietin. In cases where we anticipate heavy bleeding during surgery, like an adherent placenta or a placenta previa, we should actually plan to cell salvage and transfuse or to transfuse the mother's own blood. The NATA consensus statement is something that we also follow in Malaysia. All mothers who are pregnant actually have their hemoglobin checked at booking at 28 weeks. And in Malaysia, we do it again at 32 weeks. And if they are found to be low, then we will send off an oral, we will send off a serum ferritin, as well as we will look out for hemoglobinopathies. And in this statement, it actually says all mothers should be offered iron. If their serum ferritin is less than 30 nanogram, as a preventive measure, they can be given 30 to 60 milligram, and in a therapeutic form as 80 to 100 milligram. We know the problem with oral iron absorption, and because of hepcidin, it prevents the enteral iron absorption and transport of iron from the liver, and therefore less iron is delivered to the bone marrow to give effective erythropoiesis. In this paper, they have actually looked at administering iron every other day. And what they have found in this Swedish paper was the alternative dosing of iron may maximize the fractional iron absorption, increase the dosage and efficacy, and reduce the GI exposure to unabsorbed iron. And once oral iron is used to correct hemoglobin, the hemoglobin can be checked after 4 weeks. So when should we resort to intravenous iron? When the patient is not responding to oral iron, when there's an urgency to top up hemoglobin, and when there's a massive bleeding is anticipated antenatally, postnatally, or intraoperatively or intrapartum. At the moment, we have not given any intrapartum or intraoperative IV iron, but we are quite comfortable giving it antenatally and postnatally. And the iron required dose is calculated using the Gansoni's formula. Is IV iron safe? Now, these newly approved and safe iron formulations are quite safe, and ferric carboxymaltose iron sucrose is quite safe. And the reaction with IV iron, which was previously seen, was with the high molecular weight iron dextran that was available, which is now improved and safer to be used. So when we look at the toxic effect and the immunogenicity of iron, the one that gives us the best result is probably the ferric carboxymaltose, because it has low toxic effect and low anaphylactic risk. Previously, high molecular weight iron dextran was actually taken off from our formulary, but now with the new dextran available in Cosmofer, it is in, and we are already using it. So IV iron may be indicated when there is a need of rapid increase of hemoglobin and iron stores are required. And when in Malaysia, when we compare the price of 1 pack cell, which is about 500 ringgit, with 2 ampules of Venofer, which contains of 200 milligram of iron, we are actually paying 14 times higher for blood than IV iron. So who needs patient blood management? I think the WHO has called out an urgent need to implement patient blood management. And PBM is definitely essential in pregnancy and childbirth, looking at this literature review and expert opinion. Definitely, patient blood management demonstrates a reduction in morbidity and mortality, cost for patients undergoing surgery and medical intervention with high bleeding potentials, and all pregnant women have a significant risk of postpartum hemorrhage. So risk factors may not exist in some women who actually experience postpartum hemorrhage, and therefore every obstetric unit should practice patient blood management and focus on women who will be identified as high risk for postpartum hemorrhage. So what are the barriers to patient blood management? There are multiple barriers. The first is a lack of knowledge and interdisciplinary commitment for a PBM guideline in clinical practice. The next is, I think, patient blood management should be hospital-centered so that it's practical, feasible, and acceptable with all the departments in that institution. And what we need is, what we lack is clinical champions and strong leadership in order to establish PBM. And lack of education and training is one of those that deter people from practicing PBM because of lack of awareness. So lack of knowledge of patient blood management among clinicians can be a challenge or a barrier, and they don't think that patient blood management is high in their priority. And some of them actually think that IV iron is very expensive, and they think that blood comes for free, which is a false perception, as I have shown earlier. And there is a lack of knowledge among patients that blood transfusion is not without risk. I think in order for PBM to move forward, we need patients to come up and ask for it. And I think at every country to bring up PBM, we must have a national authority on this, and it should be endorsed and practiced by all hospitals. So who owns patient blood management? For me, I think it's everyone's responsibility. And I think if the patient is going for a surgery, then preoperatively, it would be the anesthetist, the surgeon, and the primary care physician. Intraoperatively, again, the anesthetist, the surgeon, the perfusionist, and the specialist, as well as the nursing staff. And postoperatively, again, the whole team has to manage the patient and manage patient blood management. So some bring home messages: don't neglect anemia. If we treat it soon and treat it effectively, and we may need to consider using IV iron to get a quick improvement in their anemia status. We have to know the first pillar well. It may be unique for each discipline, but definitely the first pillar is where it begins. And we need to think twice before transfusing, as if I say that you need to have a kidney transplant or a liver transplant, people will take it very seriously. But we don't realize that blood is actually a liquid organ transplant. And I feel that in every unit, the transfusion should be the decision by the senior most person, should be the consultant or the specialist. And blood bank and transfusion units should actually start questioning the reason for request for blood. And if we need to give blood, then try to practice a single unit policy, unless it's a massive transfusion protocol has been activated. Iron deficiency is important modifiable factor, and early investigation and treatment should be given before it progresses to iron deficiency anemia. So we can always resort to IV iron, and in my hospital, we are quite comfortable giving IV iron. I think in a day we have 2 or 3 patients who come in on a daycare basis and have it administered, and they are discharged. And in post-operative anemia, we should also use IV iron. So transfuse only if it's absolutely necessary, and it's the single unit policy. Assess the patient as a whole, or not just a number on the lab form. The Society of Advancement of Blood Management has said that I think if we should postpone surgery because we need to optimize the hematocrit, and we have to stop unnecessary blood testing. And we should go clinical, not just looking at numbers on the investigation. And we should transfuse if transfusion is not a default decision, and we should only do it if it's absolutely necessary. So what are the challenges to clinical leadership? The greatest difficulty in the world is not for people to accept new ideas, but to make them forget their old ideas. In our journey for patient blood management, actually, we were able to actually convince the people with old ideas, but to incept this patient blood management among the younger generation of doctors is a challenge. So when it comes to obstetrics, I think every mother is special. So stop, think, identify the cause of anemia, plan what is best for the mother, correct it antenatally, and then give her what is required, and proceed on to bring in a live baby and a happy mom. So to win patient blood management at your hospital, I would like to share some of the things that I think in my thoughts are useful. First is you need a champion, and you need to lead by example, and it must be a team effort. There must be advocacy going on, and reminders and rewards for those people who actually practice patient blood management. And there must be a change culture. Frequent audits is necessary to show evidence that it is working, and it is useful, and it is beneficial, and it is not a very difficult process. Giving IV iron is definitely simple compared to blood transfusion, the amount of paperwork that is required. There should be benchmarking, and this must be a new norm. So the PBM journey starts with convincing everyone, obtaining their commitment, making them change, and finally it will be a win when everyone is comfortable with patient blood management. So establishment of patient blood management offers a reduced risk and improved patient outcome in perioperative pathway and in obstetrics as well. There are 3 pillars of PBM, and all 3 are equally important. Collaboration and continuous effort to translate PBM guideline into clinical practice should be multidisciplinary, organized in a structured way, will make PBM the norm. So patient blood management, I hope in the near future, will be patient driven, and patients who come in will tell us they would not want blood, but they would want iron instead of blood. So please adopt and adapt patient blood management.